Hi everyone, thank you for coming and listening to my pitch here at LHRD. My name is Lisa Garland and I'm a master's student at Western University working with my supervisor, Dr. Ian Cunningham. My research focuses on developing dual energy subtraction angiography for cardiac imaging. Motivation for this work stems from the overwhelming presence of cardiovascular disease, which has been the global leading cause of death for decades in a row. To diagnose and treat cardiovascular disease, an angiogram is often performed to locate the narrowings and blockages within the vasculature. This requires the injection of a contrast agent into the bloodstream while acquiring diagnostic x-rays. Digital subtraction angiography, or DSA, is an angiographic technique used to suppress the visibility of background structures such as bone and soft tissue to enhance the visibility of the injected contrast agent. DSA requires two images: a mask image, which is acquired before the contrast agent is injected, and a contrast image taken post-injection. These two images need to be taken in identical positions to ensure the subtraction will remove those background structures. Due to the time delay between the mask and contrast image, this technique does not work for cardiac imaging since the heart's constant motion means the structures are not in the same position for both images. Multi-energy subtraction aims to have similar background suppression as DSA, but without acquiring a mask image, rather acquiring both images in rapid succession after the contrast has been injected by introducing a fast kV switch. These images are taken at different energies, so the attenuation of iodine varies much more than the other structures and can be enhanced by subtracting the images. In general, angiograms can be lengthy procedures and require a relatively high dose of radiation. On top of this, the contrast agent injected can be quite uncomfortable for patients, and sometimes the kidney has a hard time processing the dye, and this can be quite damaging after the procedure is done. There are many areas that can be improved, but my focus is to prove the advantages energy subtraction can bring to the table for cardiac angiograms. This dual energy concept has been proven to be successful previously in our lab, but under very specific conditions, such as using a spinning attenuation filter that outweighed the feasibilities of clinical implementation. The objective of my research is to develop an energy subtraction technique with background suppression similar to that of DSA while maintaining the current X-ray tube design for an easy transition to a clinical setting. To start, I want to find the optimal spectral shape for both the low and high energy acquisitions, then determine how much scatter may render this technique undiagnostic so that we can investigate ways of trying to keep the scatter within that threshold. As mentioned before, the contrast agent, usually iodine, can cause kidney damage, so we want to reduce concentration of iodine used, as well as maintaining or even reducing the average dose administered in a conventional angiogram. Moving on to methods, I think it's important to start with an understanding of multi-energy imaging. So looking at figure 1, we can see that the blue curve, which is iodine's attenuation coefficient as a function of energy, has a K-edge around 33 keV. The orange and yellow curves do not have the sharp edge, so attenuation across various energies is more similar than iodine. If we acquire two images beyond this K-edge, at let's say 50 and 100 keV, the iodine will appear much different between the two images, while soft tissues will be nearly identical. This is the premise of how we plan to make energy subtraction work. The Rose SNR criteria was used to ensure that small structures would be visible in various simulation parameters. The two metrics that we optimized for were SNR and the SNR per square root error kerma, which I'll refer to as the figure of merit, or FOM. I imaged chest phantom on our Canon Alphanix angiography system that we have here at Robarts and overlaid a latex tube filled with diluted iodine contrast. I used 4.7, 3.1, and 1.6 millimeter diameter tubing to simulate various artery sizes, and diluted 370 iodine contrast by 2, 5, and 10 times the typical full strength that is used. I also used various KV and MAS selections that were found to be the best from the MATLAB simulation. The subtraction calculations were applied afterwards in MATLAB using formulas previously determined in our lab. Another component that we found to be critical to energy subtraction success was scatter. So while considering this, we developed a novel technique to measure the scatter to primary ratio while also obtaining the MTF. And then these results were added into the theoretical simulation for more realistic results. The chest phantom images obtained are shown below in figure 2 and 3. The 370 iodine contrast agent was diluted by 5 times the full strength, and the overlaid tube here is 1.6 millimeters in diameter. So figure 2 is a conventional angiographic image at 80 kV, and figure 3 is the result of multi-energy subtraction with a low energy of 60 kV, a high of 120 kV, and an MAS ratio of 10. The resultant image impressively shows the ability to suppress soft tissue while enhancing the visibility of the simulated artery. The soft tissues and airways are no longer visible, but the bone also appears enhanced with the iodine. You can imagine if there was a narrowing in the contrast tube, it'd be much easier to see in figure 3 than the conventional image in figure 2. These images were obtained using a stationary attenuation filter, where previous attempts at dual energy used a spinning filter in front of the high energy acquisition only to further separate the two spectra. So by keeping the filter stationary, the simplicity and adaptability of this method is much more feasible. Calculations showed that the static filter reduced the SNR by approximately 20%, but for convenience we're willing to sacrifice that loss. The same simulation calculation showed that an MAS ratio of between 5 and 10 is ideal, and that we can still achieve reasonable SNR even after diluting the contrast agent significantly. For visual reference to cardiac applications, figure 4 shows a conventional cardiac angiogram of the right coronary artery. If the soft tissue suppression that we can see between figures 2 and 3 was capable of being applied to this image, the vasculature and any narrowings would be much easier to diagnose confidently. In conclusion, we can see clearly from the phantom images that energy subtraction greatly enhances the visibility of iodine while maintaining the same or less patient entrance dose, and with reduced contrast agent concentration. The decrease in SNR and FOM when compared to conventional angiography is similar to the loss that we see with DSA, which is widely accepted and used regularly. By implementing the fast KV switch and acquiring the two images in rapid succession, the chance for motion artifacts to occur is greatly reduced, which would make this method useful even in neuroangiograms if patient motion was an issue. Next steps for my research is to implement the fast KV switch that we will soon have access to and determine pulse width parameters and timing of the image acquisitions to further develop this technique and make it ready for clinical testing. So thank you very much for listening. I'd like to thank Canon Medical and CIHR for supporting this work, and I'd be happy to take any questions. And if you'd like to reach me by email, it is listed below. Thank you.